Dear friends and colleagues, today I am honored to host Professor Antonio Pellicer. However, before I begin the introduction, I wanted to say a few words about the current situation. We at IVF Worldwide have been developing digital educational content for the past few years. The current health crisis further emphasized the need for open access online education content. We are continuing to develop new contents on a daily basis, which we will continue to offer for free of charge to all IVF professionals. With this, I would like to introduce our speaker today. Professor Antonio Pellicer is known to all of us. He was the chairman of the Department of Obstetrics and Gynecology at the Hospital University La Fe in Valencia, Spain, and the dean of the Medical School of the university. He is the co-founder of the Institute of Valencia for Infertility, IVI, in 1990, and his work in the field of fertility has led to the creation of many IVI clinics, both in Spain and internationally. Professor Pellicer is the co-editor-in-chief of the journal Fertility and Sterility, and is authored over 300 textbook chapters and more than 800 journals articles. He was invited today by IVF Worldwide to give a lecture on the topic, fertility preservation for endometriosis. Professor Pellicer, if you please.
Thank you, Professor Shoham. I have to say hello to everybody and to acknowledge your invitation. Although we are facing a difficult situation all around the world. And as you mentioned, I did almost all my professional career in Spain, but since 5 years ago, I'm based in Rome. I'm Italian citizen. I feel Italian, and I can tell you that the situation that we are facing here is really dramatic. And Spain is following Italy and maybe other countries in Europe. So the COVID-19 infection, the outbreak of this infection in Europe and especially in Italy has been dramatic. And we are getting more than 1,000 cases per day. And the main problem today is that we have to stop this increment in infections, because although we know that only about 10% of the people are seriously ill enough to need an intensive care unit with respirators and the dedicated personnel, I have to tell you that since there are so many infections, the sanitary systems are collapsed, and this is the real problem. So we hope with all the measures that are being taken in all the countries, including Italy, Spain, Israel, and others, in which we stay at home and do as much as we can performing smart working, will at least stop this continuous contamination. For me, there is hope. There is hope because I totally support, and I'm very confident about the sanitary systems that we have in Europe. And by the way, we will never thank enough all the people that are involved now in treating these patients. Yesterday was amazing to see in the social different social networks how people go out of the balconies and applaud the medical personnel. It's really amazing, not only in Italy but also in Spain. I mean, people understand the work of our colleagues, and we as citizens, because our work is a little bit outside of the problem, in the sense that we are not dedicated to this branch of medicine. As citizens again should behave and definitely support our colleagues, stay at home, support our colleagues, and hope that in a couple of weeks, and definitely in a few months, with the high temperatures come, the situation is resolved. And for the next winter, hopefully we have enough vaccines or methods to protect ourselves from this situation, from the virus. So sorry for this introduction, but this is absolutely necessary. Otherwise, people don't understand what I'm doing at home today, and it's easy to understand. So Professor Soham asked me to talk about something that could be of interest to you. And I came up with the concept of fertility preservation in women with endometriosis, because you can already find a manuscript online in Fertility and Sterility, in which the first author is Anna Cobo, which will be the basis of my presentation. And I think these data are interesting, and that you really can learn something new and quite robust about preservation of fertility in women with endometriosis and the quality of the eggs in patients with endometriosis. So we really know, and it's clear to us, that women who have endometriosis have a problem if they undergo surgery, because due to the removal of healthy tissue, or due to the inflammation after surgery, or the methods employed electrosurgically, in the end, many of the ovarian vascularization is impaired. And as a consequence, what we get is a reduction in ovarian reserve that has been shown in many manuscripts, in many papers. I'm just showing here the picture here is from a meta-analysis to illustrate the concept. But again, there is a lot of literature showing that serum AMH or antral follicle count in women previous or after surgery makes a big difference, and there is approximately a 40% decrease in ovarian reserve after surgery for endometriosis. So, and because of this, many guidelines, included the ones by HRED that I'm showing to you in this slide, recommend to evaluate with the patients the risk of losing ovarian reserves and therefore losing fertility when the patients undergo surgery for endometriosis. And in this regard, we should consider oocyte vitrification, oocyte storage, because it could be a method to avoid the unintended damaging effect of surgery. And if we look at the different indications for fertility preservation after the whole technique of oocyte vitrification was established, one of the indications is endometriosis. There are others that I'm not going to discuss today, but endometriosis is one of them. And this presentation that I'm showing you today deals in the first part of this of the presentation with data that we have been able to collect and published recently, again in Fertility and Sterility. The numbers are, to my understanding, high enough to be considered, in the sense that, as you can see here, more than 1,000 patients came to our units to preserve fertility for endometriosis, and the paper analyzes a total of 485. So basically 500 women that in the first table here on the right-hand side of the slide, you can see how they are women who were at the age of 35.7 years of age. The second interesting point to mention is that out of these 500 units, basically all of them, but 11 were severe endometriosis, and that approximately half of them underwent surgery before coming to us. Others came to us before surgery. And this is an important point to remark, because you will see how there are huge differences between women who had surgery before fertility preservation or not. So the second slide of the manuscript prepared and again put recently by Anna Cobo in Fertility and Sterility online compares outcomes according to age, because age, you know, that is a main driver of our results, of our outcomes. And this slide separates women older or younger than 35. And the first row that I would like to highlight is the one that shows the number of mature eggs that we were able to freeze. And obviously there is a difference between younger and older women. We can say expected difference. And also we see that there is a difference in survival. And let me make a parenthesis here to make clear that survival rates after freezing and thawing is considered today a very good marker of quality, a fundamental KPI of quality. So if you have a patient with a problem, you have an older patient, survival is always lower. So in some way reflects the quality of the egg. So keep this number, 85% survival in endometriosis if the patient is younger, much worse if the patient is older. So the responsibility here for this decrease is obviously comes from the age and not from the endometriosis, because in both columns we have women with endometriosis. And when we go to pregnancy rates, the same figure appears. So it doesn't matter if you consider clinical pregnancy rate, ongoing pregnancy rates. Ongoing means more than week 25 of pregnancy, or cumulative live birth rates. So in cumulative live birth rates, starting from more eggs and having the opportunity to replace more embryos, in the end, you see significant differences between younger and older patients. Now, if we go to the next slide, this is a slide in which we again divide the patients as having less than 35 years of age or more than 35 years, because as you have seen and everybody expected, that makes a difference. But now we want to analyze previous surgery or not. No surgery before, surgery before fertility preservation. And here, again, you can go to the paper, so I'm not going to employ much time analyzing all the tables, but I go to this row in which we analyze the number of oocytes frozen, metaphase 2 oocytes. And obviously, a clear figure shows up. And if the patient didn't get surgery before, you get more eggs. It makes a lot of sense, but again, it's important to show this data that, to my understanding, are the first that are published in the literature. And again, the consequences of age in the other columns are obvious. When we go to survival, you don't see differences in survival between previous surgery or not, because the fact that the patient has undergone surgery does not affect your survival rates. But again, taking together the two columns of women younger and older than 35, then you see differences. These are in the range of the 85%. These are in the range of 80%. And regarding cumulative birth rates, you see differences. And obviously, the highest and better one is if you are able to get this patient before surgery, because you are able to freeze more mature two oocytes, and in the end, your cumulative live birth rates are significantly higher. Now, this slide has nothing to do with this manuscript. It pertains to a paper that Anna Cobo published in Human Reproduction at the end of 2018. But the slide is similar to the one that I showed you in fertility and sterility. But here we have younger and older than 35. But these patients are those who preserve fertility for the so-called social reasons, so elective fertility preservation, healthy women. This is onco patients. And here you see how the survival rate in young women who preserve fertility without any additional disease is over 90%. And in oncological patients is 80%. And if the patients are older, obviously this is also affected. And this is live birth rates about 70%, let's say 69% in younger patients when they come back to get their eggs to become mothers, and in onco patients is lower, and also age has a tremendous effect. Now, if I put together for you, and I did not realize I didn't know perform statistics, because this is just to show you the effect. Social freezing in young women is similar to our gold standard. Our gold standard, if you see the down here on the bottom left bottom of the slide, maybe are the donors. And we know that in donors, we retrieve about 12 eggs. In women younger than 35 that come for fertility preservation, we retrieve 9. Women with endometriosis that had not undergone surgery before, they have 8.6 eggs per woman, which is, again, I didn't perform statistics because it was not the case, but it looks very similar to what you can get in young women without freezing for social reasons or oncologic patients. Now, if we go to survival, that is, again, a marker of quality, and that's important, and we look what we get in donors, again, here on the left, 92%. In young women with social freezing, basically 92%. So in both cases, over 90. In endometriosis, we have 6 points less. And this is young women. So this reflects, to me, is another sign, another clinical picture showing that the quality of the eggs of women with endometriosis is impaired. We saw that in many publications over these 40 years of IVF, although the results are controversial. But I want to make the point again about the quality of the eggs in women with endometriosis, because even in younger women, you see clear that they don't have the same outcomes that they should, according to their age. And obviously, the situation is worse for oncology, but oncology is not the topic today. So, in the second part of my talk, I just would like to go over this concept, the quality of the eggs in women with endometriosis, because when we advise our patients, it is clear that they can become pregnant with IVF. It is clear that they will become pregnant after IVF. But apart from many other reasons that could decrease the fertility of patients with endometriosis, in the best review articles that you find in the literature, you always find altered oocyte quality. And this was based on clinical data. But today we can add the data from vitrification that I'm presenting for you for the first time in this seminar, in this webinar. And also there is a series of studies published in the literature until 2017 that you can find summarized in this review paper coming from Italy, in which the authors analyzed several papers from which my group contributed with a few papers, and in which you will find how the steroidogenesis in the follicles of women with endometriosis is different. There are folliculogenesis alterations. There are the oxidative stress is different. More recently, people have found differences in the number of mitochondria and also the quality or the appearance and function of those mitochondria. Also, anomalies in the spindle, and I'm talking only about human data. And recently, just at the end of last year, we published a paper looking at the transcriptomic profile of the eggs of women with endometriosis. Until now, we had the big problem that for analyzing at the molecular level the oocytes of women with and without endometriosis, we had to collect many eggs. Since the single cell RNA sequencing technology was available, we applied it in our foundation, and we were able to compare women with endometriosis with unilateral and bilateral endometriosis with women without endometriosis. And again, the paper is published. You have here the reference. I shouldn't go through many details, but just let me show you that if you compare the differentially expressed genes in women with and without endometriosis, you end up with more than 500 genes differentially expressed. And what is also interesting is that in women who have an ovary affected and women who do not have the other ovary affected, the differential expression is very low. It's only one gene. So showing that whatever it is an effect that is a systematic effect. It's a universal phenomenon that is inherent to that patient and is present in blood and affects both ovaries, whether they have endometriomas, visible endometriomas by ultrasound or not. Now, when we classified the genes that are expressed in these patients and see the global transcriptome behavior, you see here in orange the healthy donors, and in blue the affected individuals, either both ovaries or only one ovary. And here there is another way of classifying the genes, which is very useful, very visual, because you can, from here you can infer immediately that the genes expressed in healthy women as compared to women with endometriosis are totally different. The picture is totally different. But if you come back to these PCA classifications of the genes, you see how in reality 69%, so almost 70% of the oocytes from endometriosis patients behave differently from healthy donors. So again, women with endometriosis have normal eggs? Absolutely yes. But it looks in these basic studies that we can say that in these patients, 70% of the oocytes have genes that are differentially spread from those in healthy women. And when we look at the 20 top differentially expressed genes, and especially when we identify these genes and correlate these genes with some functions, it turns out that some of the most differentially expressed genes are related to steroid metabolism, others to the oxidative stress, and some others to the cellular cycle. So all in all, this data, basic data that have been possible to obtain thanks to the technology of single cell RNA transcriptome analysis, tell us that eggs from women with endometriosis are different. So to conclude, I think that we can conclude today that regarding fertility preservation, which has been the first part of my presentation, today we have robust data, almost 500 patients, 1,000 patients who froze eggs, 500 who came for those eggs, to get these eggs to become pregnant. Although they are not very high, but 500 patients, I hope you agree with me that at least tell us some signals where we are and where we stand today. Maybe in the future, when we have more patients, we may change a little bit our messages. But today, our message tells clearly to you that survival is lower in women with endometriosis. And to us, this is another clinical evidence that something is wrong in these oocytes. Maybe only 70%, as the basic studies show, but something is different because survival is different. And the second important message of this paper, I think that is clear. If you can, freeze eggs before the patient undergoes surgery, because the outcomes are totally different. You have more number of eggs, and in the end, your cumulative live birth rates are significantly higher. So you should go for that if possible. Regarding the quality of the oocytes, this is the second part of my talk, just to give some basic support to what we have seen clinically using the fertility preservation program. But basically, apart from data that have been generated in the past, today with new technologies, with molecular biology, we have more proof of concept. We have more data showing that the oocytes of these women are different looking at its transcript. And I thank you very much for your attention and for being here. And again, be sure that we will get out of this terrible situation, and hopefully all together in a couple of months look at the future in a different way as today.
Thank you, Antonio, for a very exciting and stimulating presentation and presenting new data. I have a couple of questions here, and one of them, is there any relation to the size of the endometrioma, when to operate and not to operate? Should we stimulate all sizes of endometrioma before doing surgery?
Well, in this study, we didn't look at the size of the endometrioma, only if the patient had severe endometriosis or not. So it was, we followed the classification of the American Society for Reproductive Medicine, the old classification. But I think the message is the same. I mean, the message should be, if you have a young woman who has an endometrioma and for whatever reason you want to operate it, if she's considering to have babies, it's better to freeze eggs before you even perform the surgery. Obviously, the surgery with a 2 or 3 centimeter endometrioma will be much easier than the surgery with an 8 centimeter endometrioma, I'm sure, and the damage will be lower. But I wouldn't take this risk. I would recommend our colleagues today to freeze eggs before any surgery.
And based on the clinical study that you actually showed us, would you recommend a higher stimulation at the beginning or a more aggressive stimulation in patients with endometrioma in order to get more eggs? So initially increase the dose of gonadotropins?
Yes, I mean, well, you know that there is a lot of controversy about minimal or regular stimulation, etc. So I don't want to enter in this discussion because this is all in all another topic. But I'm on the belief that we should get from a woman as many eggs as possible, because I'm convinced that it's very, very, very seldom that you can find a hyperstimulated woman. And if I have to treat a patient to freeze eggs and I have to stimulate the egg, the ovaries, I prefer to do it once and not to repeat it again. So I will go for an aggressive, you know, you can get an idea of how many eggs you can get because you can count the antral follicles, and this is a very good marker of the number of eggs that you are going to egg. But I wouldn't say go mild, because in this way you are going to reduce the chance of this patient having endometriosis.
Thank you very much for a very stimulating presentation. Obviously, endometriosis needs a lot more research, and hopefully we'll have some answers in the near and far future about this disease. Maybe we'll be able to do something to decrease the damage of endometriosis on oocytes and ovary. But thank you very much again for being with us today and giving such an interesting lecture.
Thank you. Thank you to you for giving the opportunity to communicate with the whole community, and again, especially in these days.
Thank you.